with a suture and basically tie it down, anchor it down to prevent this fluid leaking out. But again, it's not for everybody. You have to see a doctor in order to decide what's a good option for you. And again, this is mostly young patients who got these procedures, and it all depends. And you can see it's fixed with little suture down there. We use it a lot for knee arthritis, and the results are, it's basically called debridement of the knee. And we're washing out all these inflammatory agents, what's inside of your knee. So it's a temporary relief in terms of progression of arthritis. We're not fixing the problem. The arthritis will still progress, and the hip or knee will get eventually worse. What arthroscopy allows us to slow down the progression, treat the symptoms, and it's evolving surgery. Then we come to different techniques we can use. This one called microfracture. So if you have a bald spot on your cartilage in the knee or in the hip, we use those special instruments so we can break this bone and create new cartilage. We can't create the cartilage the same like you had before, but it's called fiber cartilage. It's not as strong, but if this is a second look arthroscopy, and you can see that it's filled up. It looked pretty good. And again, it's very specific indications for this kind of procedures. It has to be a small lesion. X-ray has to be looking normal on X-ray. So usually we find out on MRI or on an arthroscopy that it's treatable this way. And then we come to the bigger defect in the knee or hip. So we can use, it's called mesoplasty. So we can take the cartilage from healthy part of your knee and move it to the area where the defect is. And you can see my intraoperative surgical slides, and basically we take the cartilage from one place and you donate for yourself, and we move it around. And again, this is mostly for young people who has had some trauma to the cartilage that got shear off. This option is not available if you have arthritic knee. And if the science progressing, now we even have, we got FDA approval for basically cell transplantation. We're able to take your chondrocytes from your joints, and what we do, we create little flap. We take it from the bone, we take a periosteum, we sew it down in a defect, and we can inject your cells back. And this is probably the future of this process, so that we can actually transplant the cells, and we're actively working in this direction. But also, as you can see, it's also not for osteoarthritis right now. And then we move to a different array of the options, and you probably notice we all have some kind of a deformity in knee. We have, somebody has knocked knees, somebody has varus knee, so-called. This is one of my patients who had trauma, and you can see one of his legs is completely straight, and the other leg is basically deformed. So what we do for this kind of patient, when he walks, you can see that this compartment has no white lines, so it's fine, but this compartment developing arthritis slowly. And he's a young patient, he's working, he has to run, so for these people we have options to correct this deformity. So we use different devices, external, we do osteotomy. We cut the bone and we make the leg straight again. I think this patient, he already back to running and doing well. Again, this is temporary option. Most likely, if arthritis started in your knee or hip, it will progress. So this procedure postpones the arthritis. We don't know for how long, for 7, 10 years. Those options are, this one we do the same thing, but without bulky external device. We just do it with plate and screws to make the leg straight. And again, most likely they will have a knee replacement in the future, but we can say if you do it 7 or 10 years later, it's already a big achievement. This one is a different option. It's called partial resurfacing. We have it available for knee, shoulder, and foot arthritis. And we use it for vascular necrosis. It's basically look like metal buttons. They go into your knee and replace the defect. It has to be very local disease in order to use this kind of a device. And it's very new, and we don't have a long-term results on these devices. Then we move to sort of going up on the ladder. It's a unicondylar replacement. When you have arthritis in only one part of your knee and the other part is still intact, so we can replace only half of the knee, so to speak. It's not for everyone, but again, it's usually for people who have no deformities, who people has just localized pain on one side, and you have to be young for this procedure to be done. And you can see on X-ray, today you got familiar with arthritis, you can see that this part of a joint is still open. We can see cartilage here, and the other side is collapsed. So this joint is partially replaced, and you can see how this replacement look. And you can do it for different aspects of the joint, to replace the patella, replace the trochlear groove, and again, it does not work as well as total knee replacement, and we don't have or total hip replacement. We still don't have a long-term results on this data. And basically, we're coming to the gold standard of our surgical interventions, the total knee replacement. This operation works extremely well. It's according to our literature, if we replace the knee, it should last for 18 to 20 years. So it's why all these previous options I show you is very important, because if we're trying to postpone it and do this operation late in life, and but if you're already at this stage, so this is probably the best operation to do. And this is how the knee replacement. There is many different versions of this is how the knee replacement look. And moving to the hip, we also have different options, and you probably already heard about it. There is a total hip replacement and hip resurfacing. Again, it's all depend how much damage you have in your hip, and the difference is with resurfacing, we just change the cartilage, sort of replace the socket and the ball itself. With total hip replacement, as you can see on the bottom here, it's the stem goes all the way down into the femur. It's sort of a resurfacing is sort of a bone preserving operation. If you're very young, very active, if you're going to run on your hip, it's probably you have to think about this option. If you older and you have not as physically active, so the gold standard would be a total hip replacement. And this is how the replacement look. You have a socket that goes into the acetabulum, you have a ball that replaces your hip, and basically a stem that goes down into the femur. And this is probably one of the best operations available in orthopedics, because the recovery time is very quick. You will be able to walk the evening of a surgery or next day after surgery. And I mean, it's important to know your options, because this operation will change your lifestyle. So basically, if you couldn't do something, if you have a replacement, you will definitely improve. And we have multiple examples of famous golfers and tennis players that what they can do after the new hip. And this is how the resurfacing look like.